can use the anatomy to inform what to look for and that sort of thing. It's going to be some overlap. I don't know if any of the MGH residents are going to stay on the line, but if they did, it would be a little bit of overlap with Shamir's lecture from a week or two ago. And in fact, some of the radiographics article that he authored with a few other folks that I sort of borrowed from heavily in these first few slides. So the structure is going to be brief intro to the anatomy, just like a discussion of some of the different spaces and the fascial planes that make them up. And then we're going to jump into some cases. And please feel free to interrupt if you have any questions or anything. This is meant to be for you, so if something's not clear, please let me know. So this is not an exhaustive list of the spaces we care about, but it is sort of what we'll be focusing on. And specifically, I was going to focus much of the talk and the cases on like suprahyoid neck. So the most important spaces in the suprahyoid neck are going to be the masticator space, the parotid space, the sublingual space, the submandibular space, and the parapharyngeal spaces. And we'll have some images to help illustrate those in a moment. And then some spaces that sort of extend both in the suprahyoid and infrahyoid neck are going to be the retropharyngeal space, the danger space, which we hear a lot about, and then the prevertebral and paravertebral spaces. We're really going to focus on these two in our discussion today. So this is taken directly from the Shamir's paper, and it's a very busy picture, but I like it because it illustrates basically each one of these colors is one of the fascial planes of the deep cervical fascia. So here we have a picture from the infrahyoid neck, and this is from the suprahyoid neck. However, the colors correspond. So there's a superficial layer of the cervical fascia. I'm going to review this anatomy, but I wouldn't get too caught up in it, like the nomenclature. The more important thing is that you understand is that different sort of fascial planes invest each one of these structures in the neck. But anyway, for completeness, the deep cervical fascia has three layers. It has a superficial layer in blue, a middle layer in green, and a deep layer in red. As I said, each layer invests different structures. So the superficial, sort of not surprisingly, in the infrahyoid neck and develops the SCM, and then sort of comes around circumferentially. In the suprahyoid neck, this superficial layer is going to be the layer that surrounds the parotid. To make the parotid space, it's going to surround the muscles of mastication here. Can you guys see my cursor, by the way? Hopefully you can. It's going to invest the muscles of mastication to make the masticator space, and then also it involves the muscles as it does in the infrahyoid neck. The other, and so that we're going to focus a little bit on that because we're going to talk about the masticator spaces and the sublingual and submandibular spaces as well. And then the middle layer sort of it invests all the visceral organs of the neck. So like sort of it's deep to the pharyngeal mucosa, but everything else is going to be, in terms of the viscera, is going to be invested by the middle. And then the deep layer is going to surround the paravertebral muscles, both the prevertebral and paravertebral. And then there's sort of an interface right here, which I'll explain more in a moment. But the deep layer and the middle layer form a sort of compartment here. So this is the retropharyngeal space. And then there's a potential space called the danger space, which we'll go into a little bit more detail just posterior to that. That is pretty important for like complications of neck infections. So there you have it. There's 3 layers of the deep cervical fascia, and they sort of, um, invest uh, themselves in different things, and they're various barriers to spread for malignancy and so forth. Infections often transgress these borders, but they're helpful to sort of get a sense of what's going on because different processes sort of tend to happen in different spaces. Here's another depiction of those spaces, sort of color coded on an MRI. There are a few bit like I've simplified some of the spaces in our earlier discussion. There's a couple more here we haven't talked about yet, like the buccal space, but basically it's the same idea. The muscles of mastication, that's going to be the masticator space. This is the parotid, so that's the parotid space. We didn't discuss the pharyngeal mucosal space, but that's another space, and it would be bounded here by that middle layer that we talked about, whereas the superficial layer is the one making the boundaries of the parotid and masticator compartments. There's also the parapharyngeal space, which is sort of this fat that sits medial and anterior to um, the vessels. And in fact, there's like a pre-styloid parapharyngeal space, which would be this, and then there's a sort of a post-styloid parapharyngeal space, which tends to involve um, the great vessels there. And then this would be like the paravertebral and prevertebral space. Okay, here's a little bit more detail about the masticator space. So just how you might identify it on a set of, these are axial T1 or axial and coronal T1 weighted images. And some of the structures are labeled in this, and the borders of the space are um, delineated here. But basically, we have the masseter muscle. I mean, it's all the muscles of mastication. So you have the masseter muscle. This is the ramus of the mandible. This is the medial pterygoid. Here we have the temporalis muscle sort of inserting on the ramus. And something to keep, and then here's a sort of a coronal depiction of it. One of the important features of this space is that it involves, the pterygoid muscles, but also the fat and nerve, like the foramen V3 division, which comes out of the foramen ovale in the infratemporal fossa here. So actually, one of the things you have to be concerned about if you have either an infection or a malignancy in the space is that because there's a large skull base foramen here, pathology can track upwards through the nerve, through the foramen, and into the brain, or at least the intracranial compartment. So if you do have something going on in the masticator space, because of that sort of anatomic, uh, because there's a foramen here, you have to be concerned, and you should scrutinize the skull base carefully. Something else to keep in mind is that a lot of the infections we're going to talk about are odontogenic, meaning they're due to dental disease, and you tend to get masticator space involvement when you have like something on the mandibular set of teeth, and particularly like slightly more anteriorly, because if they're going to be posterior, they're instead going to be involved in either the submandibular, probably the submandibular space. So the submandibular and sublingual spaces are both on the floor of mouth. This is a cartoon sort of taken sagittally, like, the half of the jaw has been cut away here, and we're just looking sort of from the side. And the most important barrier here, or like landmark to keep in mind, is this mylohyoid muscle, because that is a sling. This muscle, to review, kind of goes from it's like a flat muscle that goes from either side of the mandible and forms a floor. Above it is the sublingual space where the sublingual gland sits, and below it is the submandibular space where the bulk of the submandibular gland sits. Importantly, however, this mylohyoid muscle is sort of incomplete. So it forms a barrier between the sublingual and the submandibular space, but there's a passage at the end, posteriorly, where these two spaces are continuous. So you can have pathology that goes from the sublingual space to the submandibular space and vice versa. Also, something to keep in mind is that occasionally there are defects in the mylohyoid muscle. So, you can get things that go transgress this border like that. That's what a plunging ranula is when it's a ranula that leaves the sublingual space and goes into the submandibular space. And then also the duct for the submandibular gland goes through the sublingual space. Here's another depiction of that. It's an important landmark. So this is like highlighting the mylohyoid muscle because this is sort of the barrier between them on CT. And this is like sublingual gland, submandibular gland, genioglossus muscle. So so these are just like, labeled some of the muscles and glands here. But the important thing to keep in mind is how you might identify this muscle on axial images. So it has this sort of band-like appearance on axial, and then on coronal, it's this kind of sling. Below it, you should see the submandibular glands, and then above it, you have the muscles of the tongue and also the sublingual glands. Okay, so moving on to some of the spaces we mentioned earlier that are both like suprahyoid and infrahyoid location. This is also an image taken from the radiographics article Rory shared with you guys, and this highlights a couple of important things. One, the retropharyngeal space, as we alluded to, is posterior to the pharyngeal mucosa, like the oral pharyngeal and nasopharyngeal mucosa, and it like this the retropharyngeal space is not a potential space. It's things normally live in it. Basically, there's fat, there's lymph nodes, there's some vascular structures. They don't tend to be large, but sometimes if you have like really medialized carotids, they can be near this. Anyway, right behind it is this danger space. So the important thing about the retropharyngeal space is that it does not continue inferiorly. It ends about at the cervicothoracic junction. However, the danger space in red here continues, and so one potential complication of a retropharyngeal abscess is that it can continue into the mediastinum, which is that's a really important thing to be aware of, so that you scrutinize, if you're reading a CT-NAC, say that you scrutinize the mediastinum to make sure that there's no spread, because that can be hard to identify because the symptoms are sort of nonspecific sometimes, and it's also a devastating complication. So very important to scrutinize. However, you are not going to be able to, only very rarely, so I would say almost never, can you see this. There is a fascial plane here, but you can never see it, or it's very, very difficult to see. And certainly on the CT, you're not going to see it. So you're not going to be able to distinguish really a retropharyngeal collection versus one that's in the danger space, other than the fact that if the collection extends like too low, say it's extending to like T1 or T2, then you got to be suspicious that it's in the danger space. And like another thing to keep in mind is that it's not, even if something was in the retropharyngeal space, they can, as I said, infections can transgress fascial boundaries. So it can definitely spread into the danger space. So something to be aware of. Okay, so anytime you're reading a chest, or excuse me, this is really true for anything, but especially in the neck, the biggest and most proximate danger is that you get airway compromise. You can imagine, particularly in kids, but in adults as well, if there's a lot of edema, there's going to be a mass effect on the airway, and this is something that can kill somebody within minutes. So it's very important to report any airway narrowing if it's present. You can get thrombophlebitis of the jugular vein, which is what Lemierre's is. You can get, in the case, if you have infection that's sort of eating away at the wall, the carotid This is more common in like a mycotic aneurysm, but it can happen outside in as well. You can get it sort of a carotid blowout. And then I mentioned already one complication that you got to be on the lookout for would be mediastinitis if there was an infection in the danger space. But you can also get intracranial extension of infection. So that's a brief overview of the anatomy and some of the complications. And then I thought it would be most useful to go over some cases, and we could sort of illustrate some of the things we were talking about. So I'm going to share my screen. Okay. Hopefully everybody can see this. And this is a normal neck CT. So I just wanted to go over some of the structures and the spaces we were talking about, not just on static images, but how you might actually encounter them in a CT. So there's an neck CT, contrast enhanced. And here would be the masticator space, right, extending up. And you have foramen ovale right here. So that, again, keep in mind that infection can spread, and malignancy, perineal tumor spread can spread to the skull base that way. And then you can also see how, if we're looking at the masticator space, which again is right here, if you had some sort of, say this person had like a periapical lucency or some sort of odontogenic infection, they're actually missing some teeth, so normally they go a little bit further back. But you can imagine how like an infection could involve like a periapical lucency, say it transgressed this cortex, and then now it's involving the masticator space and it's spreading up. Next on our list would be the parotid space. You don't tend to get primary parotid infections, but you can if this is the parotid duct here. Or excuse me, that's not the parotid duct. The parotid duct is right here. You had like a stone, and then you had backup. You had parotiditis that could inflame this space, but it sits also right next to the masticator space, so sometimes it's involved sort of secondarily. One major common source of suprahyoid infections is like a tonsillar abscess or peritonsillar abscess. So these are the palatine tonsils. We didn't discuss them much, but they can spread into adjacent spaces just as the masticator space, like odontogenic infections, like we mentioned. Here we're seeing parts of the sublingual space. This is probably the mylohyoid right here. And then I find the submandibular and sublingual spaces are easiest to see on coronal. So here we have the mylohyoid, and then above it would be the sublingual spaces, and below it is a submandibular space, and you can even see a little bit of the submandibular gland there. And then if you look on sagittal images, just sort of drives home the fact that that's like the posterior border of the mylohyoid, which ends like right pretty much where the submandibular gland sits. Okay. Some other spaces that we talked about, this fat here involves sort of the deep lobe of the parotid and the fat lateral to the pharyngeal mucosal wall. This is going to be the parapharyngeal space. And then some of the other spaces we talked about. So this is the retropharyngeal space right here. Sometimes easier to see on sagittal images, I think. You should see this nice thin stripe of fat on CT. If this fat is lost for whatever reason, you can have like a retropharyngeal effusion or potentially some sort of infection. And I think that covers a lot of the ones I want to talk about. One other big item, which I have a lot of these cases because it's very common and I think underappreciated, or at least I didn't appreciate it until I started seeing a lot of them, is that like the teeth are the source of a lot of infection in the head and neck. And if you have a maxillary tooth issue, it can cause disease in the maxillary sinuses, and that can have bad outcomes. It can have spread to the orbits or intracranially, or potentially even like elsewhere. Like sometimes you can get spread this way. This is also the masticator space, like posterior to the maxilla. Okay, so enough of that. Let's do a case with like some actual pathology. So I'm going to just go. Let's start with. I don't know. Have you guys been doing like taking cases? I can just narrate. Well, how about this? If anybody feels like they know what I'm showing, feel free to shout it out. Otherwise, I'll just show this for a moment and then I'll start talking about it. So we have axial and coronal CT, contrast enhanced CT. I think symmetry is always helpful. So if we're looking at the right side here, and I want you to sort of consider what space we might be looking at. It looks asymmetric, right? Fat is your friend. This fat looks very clean on the left side. There's not any stranding or edema within it. But if we look at the other side, here's the platysma muscle, by the way. That's technically the most superficial layer of the cervical fascia. We see deep to the platysma, like sort of anterior to the right submandibular gland, which is right here, and lateral to the anterior bellies of the digastric, which we can see right here, probably better on the coronal images. That's the anterior belly digastric. There's the arrow sign. There's a bunch of stranding, right? There's like some sort of inflammatory process. There's swelling, there's edema. So you're suspicious for an infection probably but it could be, this doesn't have to be infection, but it could be, or probably is, affection of the right submandibular space, right? And so why might that be? Well, I keep on harping on this, but 9 times out of 10, that's going to be odontogenic, right? So here we have a periapical lucency of this right second molar, and you can even probably see a little, there might be a little dehiscence of the lingual cortex there, definitely there. And that's the most common reason for infection. Something to note though, like the reason this is involving the submandibular space and not like the sublingual space is that this is a molar that's infected. So it's like the root of the molar is below the insertion of the mylohyoid, which is like kind of here, and the root of the molar is like right there. So the mylohyoid's inserting right here, and the like infection is leaving the bone right there, so it's below it, so it goes to the submandibular gland. If you have like a more anteriorly located tooth, that's probably going to go to the sublingual space. Okay, so you would report that, you would report this submandibular like cellulitis probably because there's no organized collection here that you could drain or intervene on. And you would say it was odontogenic. I think something to note here is even though this is, there's a fair amount of inflammatory change here, cellulitis and stuff, but there's no abscess. And even despite that, you already see sort of effacement of some of the contours of there's mass effect here. And so you can imagine if you had a more rip-roaring infection, you could start to compromise the airway a little bit. Let's go to a more dramatic example of something similar. So this is a gentleman who's he's diabetic, right? So they're more prone to infection. And I don't know if anybody would like to comment on what they see. It's similar but much more extensive process to what we saw before. So here we have not just the submandibular space, which is definitely involved, but there's also edema within the pharyngeal mucosa. There's much more mass effect on the airway, right? It's like almost displaced laterally. I don't know, maybe there's some involvement of the sublingual space. It's difficult to say. That looks kind of symmetric, but There's one other big finding here, which I'm showing in this image and maybe this image, that you want to be very cognizant of, which is in addition to the like pharyngeal edema, you have the retropharyngeal edema, right? So this is one of the this is sort of the deep border of the visceral fascia and the mucosal space. So here we have the retropharyngeal space. It's not clearly extending below. Well, one thing, it's not a rim enhancing organized collection. So I think one thing that's commonly overcalled probably is a retropharyngeal abscess. We generally don't call that until there's, for sure if there's gas in this space, but unless there's like a thick rind of peripheral enhancement, it's best to avoid calling it a retropharyngeal abscess. You can also see, so this has started as a right-sided process. It spread because the retropharyngeal space drains, has a lot of lymphatic drainage. Like you'll often, it's not uncommon if you have an inflammatory process elsewhere in the face or neck to get a retropharyngeal effusion. But then now that's a midline structure, so it can spread to the other side. So there's, there's inflammatory changes in this fat here on the left side too. So this guy's got like a perforating cellulitis in the submandibular space on the right, extending to the uh, extending to the retropharyngeal space, and there's also sort of secondary involvement of some of the other neck structures. So this was July 24th. A week later, he got some follow-up imaging, and I think at that time you can see that his symptoms have really developed. So what you see now, that's maybe a little bit more dramatic than what you saw before, right? So the cellulitis has turned into like a full-blown abscesses, like gas forming process. You can see he's got like tremendous distension and edema. So you can, but here's a good illustration of the fascial plane. So like the superficial border here is the platysma, and then just north of that, or excuse me, just deep to that is the mylohyoid muscle there, and then see sort of really blooming of the infection within the submandibular space. But now there's gas, so that's highly suggestive of like a fluid collection or a drainable abscess. And actually, if you keep going inferiorly, he's got also this collection anterior to the thyroid gland. So we didn't talk about the infrahyoid spaces, but this collection sort of bounded by the carotid space here, the thyroid cartilage or thyroid here, and then these are the strap muscles here. So he's got a collection there, and then it all seems to be continuous, right? He's got this process in the pharyngeal mucosa on the right, and then, I mean, most notably, he's got this big retropharyngeal, and this is like, you can feel comfortable calling this an abscess, given the presence of all this gas. So he's got a problem, and again, like we said before, there's significant attenuation of the airway here. So this is somebody who you would have to watch very closely clinically. And then just to drive home the point, we call this a retropharyngeal abscess, but you always have to be on the lookout, right? Because you can't really tell the difference between this and a danger space. You just have to look either how far it extends. If it extended clearly like back here, then you for sure know it is the danger space. But if we look at a chest CT obtained some days later, actually, I think you can see it on the study we were looking at. But so you see an infection or an abscess here, you've got to make sure to check the mediastinum. I don't know if you can appreciate, but there's this large, I mean, he's got bilateral pleural effusions, but there's also this large collection surrounding the trachea, which we get a better look at on a chest CT performed some days later. Look at this, it's sort of circumferentially encasing the trachea. He's got a big mediastinal collection, which is, it's really life-threatening complication. So Make sure you're scrutinizing. And this all started from, an infection on the right side of his face, and it spread all the way down to the medius sinus. So make sure you're checking the bottom of the images on a CT neck to make sure that there's no like mediastinal collection. I think this was visible on some of these priors, but not called until a little bit later. Like it's present here now. This was um, before the scan we were looking at in detail. So um, that is a sort of can't miss kind of finding. Here we have, let me just show you another example in the same vein, just sort of showing you, we'll come back to this one because it has something else I want to point out. Okay, let's do this one. Okay, so this guy came in because he was having like sinus pressure. And you can see he's already intubated, so that can just include like the state of his illness. But I'm focusing, these are the bone windows. So if you're going to look for like odontogenic disease, you want the thinnest cuts you can. You want bone windows because it's hard to see periapical lucencies otherwise. But I think you can appreciate there's like a full, there's clearly a defect in the floor of the maxillary sinus here. And it's likely secondary to, you can see a little periodontal widening, so that's indicative of dental disease. And then there's obviously like a large periapical lucency that has developed a full thickness sort of cortical defect. And then you get complete opacification of this right maxillary sinus. So that would be odontogenic sinusitis. There's kind of like bulging out of the sinus and into the infundibulum, the osteomeatal complex, this whole right-sided drainage pathway. So just as a brief review, like out of the middle meatus drains the maxillary sinus, the right-sided ethmoid air cells, and also the frontal sinus here. So that whole, there's like clearly an inflammatory process involving that whole right middle drainage pathway. And it's all because he's got bad dental disease. This is he's 21 at the time. So, it can get a little bit more serious than you think it might be. And then if I mentioned the masticator space can cause intracranial extension, but you also have to be worried about it with any kind of like florid sinus disease can extend intracranially, particularly if it seems to happen more often in young patients. But here's the non-contrast CT of the same patient actually taken a day before the images I just showed you. There's clearly asymmetry of this right frontal lobe. There's hypodensity, and given that it's adjacent to this sinus disease, and you might start to scrutinize it to see if you can see like any focal dehiscence. But even if you can't, you can get there are interosseous channels through the bone here where you can get spread of sinus disease into the intracranial compartment. I mean, this is a porous, this is the cribriform plate, which is where a lot of the olfactory nerves, or where the olfactory nerves go through to enter the nasal cavity. And that's like by design porous, but you can get spread from the frontal sinus even if it's not involving the cribriform plate. And he's got major issues because he's got, edema in his brain. So if we look now just on the flare, you can see he's got extensive edema here. And then the most important images would be these post-contrast ones and really the diffusion. So here on the post-contrast images, you see this leptomeningeal enhancement. And then you see on the diffusion images, this is probably a developing abscess. And then even if it wasn't, he's got cerebritis, because if you have diffusion signal here in your brain parenchyma, that is cerebritis. The other thing you'll notice here in his ventricles is he's got layering pus in the right occipital horn, actually both occipital horns. quite a bit of it. So this is ventriculitis, and this is all from bad sinus disease. Excuse me, all from bad sinus disease secondary to dental disease. So yeah, if you didn't floss before becoming a head and neck radiologist, you would definitely floss afterwards. Let me show you some of the other complications that. So we talked about a lot of things that I mentioned. There's mass effect on the airway. There's spread to the mediastinum. You can also get vascular complications. So this guy, same thing. He has like sinus disease. I forget if it's this one. He has got his dental disease is not too bad. Maybe there's a little bit here. But he got, just like we've been seeing, right? He's got stranding and inflammation in that right submandibular space. It's a little asymmetric relative to the left. And then what do you notice? It can spread sort of posteriorly, like there's a retropharyngeal effusion, again, not an abscess. And then look at this carotid sheath on the right. And compare. So this is the carotid, this is the internal jugular vein, this is the carotid, and where is the internal jugular vein on the right? It's very diminutive, and in fact, we lose it completely. So this is a often tested syndrome because test makers love it because it has like a specific bacteria that it tends to be associated with, fusiform necroform, I believe, which is like a part of the normal oral flora that it can overgrow. And then if that's the particular organism that's implicated, it's often associated with thrombophlebitis of this right of an internal jugular vein. And you can see in the jugular bulb, we have this nice, it looks good, and then it goes away. So that means it's clotted, and then it reconstitutes a little bit more inferiorly, kind of at the level of the the thyroid cartilage. So this is a named syndrome. It's called Lemierre's syndrome, and it's another thing that you're sort of obligated to look for. I realize we're coming up on time, so I'll just show one sort of companion case, which has a lot of the findings we've discussed in other cases, but it's sort of a florid example of it. So this lady is another. She had like a dental abscess, and this is how she originally presented this. She has this fluid collection, and it's involving like more than one space, but this would be involving the masticator space here, and then also there's like submandibular and probably sublingual inflammation. And here we have like it's clearly like a fluid collection. It's extending up. It also goes to the contralateral side, which we'll see more clearly on subsequent exams. This is obtained like a week or two later after that image I just showed you. And so this is one thing, if you don't get source control, like these infections can spread like to a lot of different places in the neck. And here she's got collection anterior to the thyroid, which we kind of saw in that other guy, but she's also got this a little collection, and this would be in the parapharyngeal space, and then also involving like this is another case of Lemierre's, because we don't have a left internal jugular vein, and sometimes you can get spasm of the carotid artery too if there's an infection right next to it. And I think she eventually may have also developed intracranial, mediastinal extension. But anyway, good example of some of the complications that you can see after infection in the suprahyoid neck. So hopefully you learned a little bit about the anatomy, some of the infections that you can see in the head and neck. Like I said, the most common source is going to be odontogenic, but then something I didn't really touch on, but it's also quite common to be like a peritonsillar process. Those can lead to sinusitis. Those can lead to, and the sinusitis itself can lead to intracranial extension. There can be direct intracranial extension, for instance, if it's in the masticator space. there can be vascular complications. And then one of the things you always want to make sure you evaluate, even if you don't comment on it explicitly, is that there can be mass effect on the airway. And that would be something you would call about as well. So thanks for listening. Does anybody have any questions?